I am very pleased to welcome all of you to the Journal of the American College of Cardiology's webinar on the global burden of cardiovascular diseases with a particular focus on North America. I'm delighted to be able to introduce our speakers today. We have Dr. Michael Brauer, professor at the School of Population and Public Health at the University of British Columbia, an affiliate professor at the Institute for Health Metrics and Evaluation at the University of Washington. Dr. Frank Hu, Frederick J. Stair, professor of nutrition and epidemiology at Harvard T.H. Chan School of Public Health and director of the Boston Nutrition Obesity Research Center's Epidemiology and Genetics Core. Dr. Athena Poppas, professor of medicine and chief of cardiology and director of the Cardiovascular Institute at Brown University and the Brown University School of Medicine. And Dr. Janet Wright, director of the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention in the United States. My name is Greg Roth. I'm an associate professor of medicine and cardiology at the University of Washington and the Institute for Health Metrics and Evaluation in Seattle, Washington. Today, we will be speaking about a broad range of topics related to the paper published in 2020 in the Journal of the American College of Cardiology titled Global Burden of Cardiovascular Diseases and Risk Factors, 1990 through 2019, update from the Global Burden of Disease 2019 study. This is going to be a really terrific opportunity to better understand patterns of cardiovascular disease in populations across North America and around the world, and an opportunity to understand how the latest in cardiovascular science, clinical care, and health policy can be brought to bear to address this persistent burden of disease in the world. I will begin by speaking with Dr. Michael Brauer. Dr. Brauer, a question to start us off. Air pollution is one of the leading environmental risk factors for global health and health in North America. The Global Burden of Disease study quantified two major categories of air pollution: ambient particulate matter and household air pollution. I'm hoping you can help us understand better how these two different forms of air pollution affect cardiovascular disease in North America in particular, and around the world more broadly. Can you help us understand how we should think about these different contributors to cardiovascular health? And what are the trends and drivers of these two very different kinds of air pollution?
So let's start first from a global perspective, because one of the major forms of air pollution that we're concerned with is what we call household air pollution. And this is primarily due to the cooking of in homes using dirty fuels, solid fuels like coal, wood, agricultural waste, and even dung. And this is a major form of air pollution that is a substantial contributor to cardiovascular mortality, but in low-income countries of the world, and primarily even in the rural areas of those parts of the world. In North America, we really don't have that form of air pollution prominent throughout for most of the population. What we do have, however, is ambient air pollution, especially fine particles, ambient particulate matter air pollution. These are small, invisible particles that have a multitude of sources and pollute the outdoor air. This is a global problem, but it's also a problem in North America. And it's responsible for somewhere around 30,000 deaths in the most recent year of analysis in 2019, 30,000 cardiovascular disease deaths in North America, around 4% of ischemic heart disease deaths, 4% of deaths from stroke. Contrast that with globally, considering that we have many parts of the world that have much higher levels of air pollution, this form of air pollution, outdoor air pollution, ambient air pollution, is responsible for somewhere around 20% of ischemic heart disease deaths and 25% of deaths from stroke.
That's really remarkable to think about, Dr. Brauer, a risk factor that we can't see that accounts for such a large proportion of ischemic events, potentially. When you think about air pollution, it seems so strongly associated with other drivers of cardiovascular disease, whether they're socioeconomic, other social determinants, behavioral risk factors. When you think about the choices we make about where we spend our day, where we live, and how the location we're in might impact that, how do you think about that from a health risk perspective, the complexity of all of the drivers that are tied with air pollution?
So certainly, when we think about cardiovascular disease, we know that there are many different risk factors. And as you mentioned, these risk factors have some common features. Some of them are related to levels of socioeconomic development. Some of those are related to location. Certainly from the perspective of environmental risk factors like air pollution, one of the things that's hard to control is that individuals really have very little control over what they're exposed to, which is different, for example, from dietary risk factors or things related to behavior, whether that's physical activity, use of tobacco. In the context of environmental risk factors, often where you live really determines what your level of exposure, what your level of risk is. The positive aspect of that, however, is that we can modify that environmental risk factor. So if we can improve something like air pollution, there's really no behavioral aspect to that. People don't have to do anything. They just get this benefit right away. And that's really a powerful message about this. So when we think also about controlling our other risk factors, we can also think about how can that complement control of the environmental risk factors. So for example, we're very concerned now with increasing temperatures as a result of climate change. Many of the sources, and we know that warm weather, extreme weather events also contribute to ischemic deaths, to stroke deaths. These are episodic, but the sources of climate change are similar to the sources of air pollution. So if we can reduce those sources, we will have the immediate benefits of reducing the impacts of air pollution. We'll also get the long-term benefits from not having our temperatures, our climate warming as much in the future. There's other overlaps as well. So the way that we design our urban areas, the way that we design our cities, if we're allowing people to engage in active transportation where they're increasing their physical activity, that also means less need, for example, for motor vehicle exhaust. So people are getting that benefit from their own activity, but also not contributing to the pollution that affects themselves as well as affects others. So there's just some examples.
I want to bring up a topic that certainly has been on the mind of many people in North America, certainly people who live on the western side of North America, which is wildfires. There's been I think a rapid expansion of people's awareness around air pollution due to the fact that wildfire smoke is visible and the levels have been extremely high in a number of large urban areas as well as across large rural areas. And this has been a problem both in Canada and in the United States. Can you talk a little bit first about the risk related to wildfire smoke and whether we need to think about it differently? Perhaps we don't. And secondly, whether you think it's going to change policies on air pollution at all in the United States.
So the challenge with wildfire smoke is that it's very difficult, if not impossible at this stage, to control or eliminate it. That's very different from, for example, motor vehicle exhaust, where we can apply improved technologies. We have alternatives. Unfortunately, due to the warmer climate that we have, we're pretty well locked into a future of more wildfires, some more frequent wildfires, a longer wildfire season, and actually more severe wildfires that are very difficult, if not impossible, to suppress. So that means two things. One thing, it means that we need to be more vigilant, even more vigilant to controlling the other sources of air pollution, the things that we can control. And secondly, we need to think about how we can adapt to this new reality. How do we actually have wildfire smoke in our environment, but not affecting the health of populations? Unfortunately, we do know some ways to do that. What it means is preparedness for these extreme events. So meaning that we actually have to have plans in place for especially people with pre-existing disease. Can they go to places where they can get access to clean air? Is their disease well managed in the first place? Do they have an ample supply of medication? And really, are there other risk factors also reduced so that they're less likely to be severely affected by this exposure, this risk factor that they can't change? It also means modifications to our lifestyles, our homes, our buildings, improving things like filtration of air, having air cleaners. And as many of us have learned to do over the last 2 years through the pandemic, we're now rather comfortable with wearing respiratory protection. So wearing respirators, N95 type respirators that are quite effective in reducing exposure to wildfire smoke and the harmful particulate matter in that source of pollution.
Your point that the healthcare system has a role to play by assuring that the patients most at risk are well managed to reduce the risk of bad outcomes when they are then exposed to air pollution is really interesting and worth considering when we think about the clinical care that we can provide to address risk factors. I would suggest that it is not something that most clinicians currently think quite a bit about. And I'm curious, if you had to pick the 2 or 3 most important policy interventions or healthcare system level interventions that might really move the needle on the risks related to air pollution, not just wildfires, but air pollution overall, what would you recommend? What are those 2 or 3 system level or policy level interventions in North America that you'd like to see and you'd recommend?
So first and foremost, I think clinicians have a role to play in raising awareness and advocating for change in general. So for air pollution more broadly, understanding that it's a risk factor for cardiovascular disease and understanding the aspect of it that an improvement in air quality will benefit everyone and then equitably benefit everyone. We don't have to think about targeting care, targeting delivery of clinical care. If we improve the environmental risk factors, if we reduce those, everybody benefits. That's really efficient. And there's a role for clinicians to play to advocate for that in their communities and also to increase awareness in their patient population, because those patients can also become advocates for change. And that's really how we will get change and put pressure on those that make the decisions that will improve our environment. If we think more specifically about something like wildfire smoke, where we really do need to think about community and individual level interventions to reduce exposure to this risk that we arguably will not be able to change in the next century, I think it comes down to providing individuals with a personal management plan, which is a combination of clinical care, making sure their medications are in order, making sure they have access to medications, making sure they're getting checkups, for example, before wildfire season occurs, not during the middle of an event, access to things like community clean air shelters. We have cooling centers during extreme heat events. We're starting now in many communities in the western part of the continent to have clean air shelters, and then making available home remedies such as air filters, HEPA filtration devices that people can put in their own homes, perhaps providing them for low-income populations, vulnerable populations that need it most. So if you think about, we have ways that we provide healthcare to vulnerable populations. This should actually be an aspect of healthcare, is providing a filter that somebody can put in their home if they're vulnerable to the impacts of wildfire smoke.
I think that's a challenge to the way we fund healthcare in the United States, and an interesting one to think about how to expand the package of interventions that we support for patients. I have just one brief follow-up final question for you. In North America, when it comes to air pollution and the health risks associated with it, are we headed in the right direction, or are we backsliding?
So the good news is the sources of air pollution that we can control, we've actually seen great progress in North America. It's one of the few places in the world where we've seen improvements, so reductions in the health impacts of air pollution. Western Europe also has seen some, but not as dramatic as in North America. Most of the rest of the world is not going in the right direction. What's happening in North America is really a history of technology forcing regulations and strict enforcement of those regulations, and that's what's provided those benefits. Unfortunately, now with a warmer climate, we're at risk through things like wildfire smoke, and also just other ways that a warmer climate are going to enhance air pollution. We're at risk of backsliding, not because of anything that we're not doing specific to air pollution, but because how we're not controlling the emissions related to climate change.
Thank you so much for your really informative answers and this interesting discussion. Clearly an issue that needs further exploration and an important part of cardiovascular health in North America. I'd like to turn our attention to Dr. Frank Hu. Dr. Hu, thank you for being with us, and I'll start us off with the following question for you. Not a straightforward question, but you're an expert in this area, so please tell us, are dietary risks for cardiovascular disease in North America getting better, or are they getting worse?
Well, there is no simple answer to this simple question, I guess. We know that poor diet is a major determinant of cardiovascular health based on the global burden of disease estimates. Poor diet quality is a leading cause of deaths and also morbidity in the US and also globally. So the challenge is how to define a poor diet. One of the metrics that we and others have used frequently is called Healthy Eating Index. It is a composite measure of 10 different components of diet, including consumption of fruits, vegetables, whole grains, different type of fats, different type of carbohydrates, sodium, and so on and so forth. So we have analyzed national representative data set like NHANES to look at time trends of diet quality in the US population. What we have found is that in the past 2 to 3 decades, the overall diet quality in the US population has only improved slightly. And this improvement is almost entirely driven by a dramatic reduction in trans fat intake, because 10, 15 years ago, trans fat was banned by the FDA and was gradually phased out in the US food supply. However, the overall diet quality in the US population remains very poor. And if you look at consumption of sodium and added sugar, the majority of the US population exceed the consumption levels recommended by the AHA and other national and international organizations. The consumption of healthy foods like fruits and vegetables, whole grains, nuts, and legumes remain very low, and the consumption hasn't really increased in the US population in the past several decades, despite widespread public health campaigns to increase the consumption of fruits and vegetables. And a worrisome trend is the increase in consumption of these so-called ultra-processed foods. And those foods are heavily processed, and they are ubiquitous in our food supply. Those foods include soft drinks, fast food, processed meats, and packaged foods, and so on and so forth. And typically, the ultra-processed foods contain high amount of sugar, high amount of sodium, unhealthy fats, and highly processed starchy foods. So studies have shown that overconsumption of this kind of foods contribute to obesity, weight gain, and metabolic diseases. A recent study published in JAMA found that the consumption of ultra-processed foods has increased substantially among children. Almost 2/3 of calories consumed by the US children come from those ultra-processed foods. So I think this is a worrisome trend and will have potential to exacerbate the obesity problem and cardiometabolic diseases in the US population.
It's very interesting to hear not only that dietary quality has only improved slightly over a long period of time, but there are in fact new categories of risky food becoming available. When you think about the advice that we could give to young people, what would you tell them about the choices that could be made or the things they could advocate for in their neighborhood or their city to improve healthy eating?
Well, a major problem, I think, is the so-called obesogenic or toxic food environment that people live in. So if you look at the foods in the supermarkets and in fast food restaurants, and most of those foods are highly processed and contain high amount of sodium, sugar, and unhealthy fats. They're inexpensive, they're widely accessible, and they're also very palatable. So that's why they're so appealing to young children. So I think a major public health strategy is to reduce those kind of foods in our food environment and make more healthy foods, especially minimally processed carbohydrate foods, fruits and vegetables, nuts and legumes, more affordable, more accessible, and make those foods default choices in our food environment. Of course, individual behavior changes are important, but I think make our food environment more healthy is much more important in changing people's behavior.
Is there anything you'd recommend to the medical community to have a larger impact on this problem?
Well, there is no question a medical community plays a very important role in improving patients' eating behaviors because doctors are models for our patients. And one of the most commonly asked questions in the doctor's office is about diet. So I think the simple recommendation I would give to doctors is to prescribe, write a simple prescription on healthy diet and physical activity for their patients. And of course, to write a prescription on diet and physical activity, the doctors or the health professionals need to practice those healthy diet and physical activity in the first place. And also, it's important to do diet physical activity assessment in the doctor's office. Of course, this is much easier said than done. Fortunately, simple, rapid dietary assessment tools, physical activity assessment tools have been developed. It takes only 2 to 3 minutes to get pretty good idea about the patient's eating habits and physical activity levels. And then based on that information, I think the doctors can write a simple prescription about major dietary areas that need to be improved for the patients.
I really appreciate your focus on what I think are vital aspects of a public health perspective, high quality data collection, and a systems view of things, so that it's not all about choice, but it's about the context where people live. And I hear that in your answers. I want to ask a question that I think gets at one of the more controversial areas in nutrition science, and I think is also confusing even to those of us in cardiology practice when we're advising our patients. And so I suspect a challenge for many people out there. And I want to talk about the balance between healthy and not healthy fats. And I was hoping you could share your own opinion based on science that you've been involved in recently or that you're aware of, to help guide us in the cardiovascular clinical world on how to think about healthy fats versus unhealthy fats.
Well, that's a really important question, because the public health message about dietary fat has evolved substantially in the last several decades. You may remember that in the 1980s, 90s, all the major dietary guidelines, including the USDA food pyramid, were focused on low-fat diet. The message is that reducing all types of fats, either low-fat diet, low-fat cookie, low-fat salad dressing, and so on and so forth. But the science has changed a lot in the last 2 to 3 decades. I think the consensus right now, based on epidemiological studies and clinical trials, is that the type of fat is more important than the total amount of fat. In other words, we should put more focus on fat quality than quantity, and not all fats are created equal. And the good fats that we typically talk about include monounsaturated fat from olive oil, from avocados, and polyunsaturated fat from nuts, vegetable oils, and from fish. And those kind of fats have been shown to improve cardiovascular health and reduce risk of chronic diseases. On the other hand, the bad fats include trans fat, which is the worst type of fat, and then saturated fat, mostly from animal products and tropical oils. And the good news is that, as I mentioned earlier, trans fat has been banned in the US. It's almost completely out of the food supply in this country. But unfortunately, consumption of trans fat remain very high in developing countries. So we still have a long way to go to reduce trans fat globally. And in terms of saturated fat, there's still a lot of controversy regarding the sources of saturated fat and cardiovascular health outcomes. And you may remember some sensational headlines several years back, something like butter is back. But I think the current evidence still indicate that higher consumption of saturated fat is bad for cardiovascular health. We're not talking about zero saturated fat. We're talking about reducing saturated fat below the current recommended level, which is about 10% calories from saturated fat. And more importantly, replacing saturated fat with unsaturated fat rather than bad carbohydrates. So I think the nuance of the fat message is that replacing bad fats with good fats rather than reducing all type of fats.
That was extremely clear. I really appreciate how you laid that out, and especially pointed out that the science is evolving and has evolved already over decades, and perhaps the messaging around that science is an area to focus. I want to finish up with just a simple question around where the science is headed. In your perspective, in your view, what's the next most important area for dietary science over the next, let's say, decade? What's the big question we need to answer?
Well, right now, I think the area of precision nutrition has gained a lot of attention. So the idea of precision nutrition is analogous to precision medicine. So as you know, for precision medicine, the idea is to get the right drug for the right patient at the right dose. In terms of precision nutrition, the idea is also to have the same food, have the right food at the right amount for the right person. Of course, this is easier said than done. But I think with the advances in omics technologies, including genomics and microbiome analysis and so on and so forth, we can tailor dietary recommendations and nutrition therapies to individual characteristics, including the genetic background, the gut microbiome composition, and so on and so forth. So this is certainly a very exciting direction for nutrition research, but this doesn't mean that we should forget about public health nutrition, the policies or regulations that I mentioned earlier, which have played a very important role in reducing trans fat and reducing consumption of sugar-sweetened beverages in the US population. So I think we need to integrate public health nutrition with precision nutrition to improve overall food environment and the individual eating behaviors.
Thank you very much, Dr. Hu. Dr. Poppas, I'd like to change the topic slightly here. We're still going to be talking about cardiovascular disease, and we're still going to be talking about both clinical and public health issues. But I want to talk about tobacco, and I'm hoping that you can bring your expertise both as a clinician and researcher to bear on this question. And I'll have a couple follow-up questions, but to start, where are we from your clinical perspective with addressing tobacco use in at-risk populations in the United States and Canada and other parts of North America as well?
Greg, I think it's a really important question, and the way you framed it, I think, is crucial. You know, from the paper, we've learned that there's really wide variation in the use of tobacco, difference in gender and difference among countries, and difference within the United States, so the subpopulations within the United States. And one of the questions is, why is that? And if we can understand the why, we can get at solving some of that. And when you ask about the clinical implications, it's really not just the physicians, but the entire team has to approach this. And I think, as Dr. Hu mentioned, it's also around advocacy. And as physicians and team members, we need to be advocates. Look at the work that's been done around tobacco to advocate for smoke-free environments. There's a lot that we know that works. So one of our problems, I think there's three things we need to know. What's the problem with implementation and uptake? There's a lot of regional variation in the states when you look at that, when you look at the tobacco use among adults and among young children, so middle school and high school. How can we change that on a clinician level? So in speaking with our patients, as pediatricians speaking with our young adults, and then advocating for adequate advertising or lack of advertising, which has made, we know it's impactful. We know that the World Health Organization is using some of those tools. They just haven't seen the uptake. So that to us, I think, is really going to be important. The example would also be e-cigarettes. Look at some of the debate around that. So we have to, as clinicians, be clear. We have to be clear in what the science is. And then we have to utilize, I think, our team members. In a 15-minute office visit, it's going to be challenging to get a physical education, a diet inventory, a tobacco inventory, but with coaches and extenders and the next visit with nurses, I think we're learning that we can do a lot more, and patients really respond to that. So I would say the take-home message is there's a lot of regional variation. We need to understand what the cultural reasons behind some of that is, and then we need to target that, and we need to use the entire team to achieve those goals. For example, that would be a start.
Yeah, it's a complicated topic, and I appreciate how you've laid out a number of different pieces. And I want to ask you specifically about e-cigarettes, or what's sometimes referred to as vaping, right? It's a complicated area where we're still trying to even understand what that exposure is. How have you seen that clinically? And do you think that there's, interventions that we need to think about implementing to better understand how it's affecting our patients?
I think for our cardiac patients, we know that as a step down, similar to say a patch to get them to stop smoking cigarettes, a very powerful drug. And we know that it can be effective in that realm. The flip side is, if you look at some of the advertising for young adults and the flavored e-cigarettes, that has the opposite effect. It gets them attached and hooked on nicotine. So I think that we know that it can be, we need to be clear on what it can and what it can't do. And I think we need to be a little more clear with our middle school and high school kids and young women. They're really targeted. There's advertising that's quite, it's been pulled, but it's quite undesirable.
I'm glad you pointed out specifically the subpopulation of younger women and the risks that they might be exposed to that will affect their cardiovascular health. And I'd like to follow up on that and ask you specifically about the risks that affect women as opposed to men, and how you think about risk factor management for women, and especially younger women who may not yet have developed some of the comorbidities that we often manage in our older cardiovascular patients. What's the risk factor cocktail for younger women, and how can we address disparities that we see in that population?
Yeah, I think it's important. I think there's another example where we've done a good job of educating people that cardiovascular disease, and by that we usually mean heart attacks, are not just a women's disease. So at least getting education and awareness, good first step. As far as younger women, we also realize in young people in general, there's a sense of invulnerability. So we've learned that there's a number of checkpoints with women. Some of it is through childbearing years. And we know that there's some high risk features during pregnancy. So how do we utilize that to educate women that have had high blood pressure, that have had gestational diabetes, and inform them? And then the other piece is some of the work that's being done. We're including women in clinical trials, so we actually have the information to better inform not only the patients, but providers, that women can present differently. They can have different atherosclerotic plaque erosion more than plaque rupture. And also that ischemic heart disease is probably better because they can have more non-occlusive coronary disease. So without sort of putting that aside. So, and what are the implications about that, and what's the treatment mechanisms, and treating them as aggressively as occlusive coronary disease. So we've learned a lot, and it's not only educating, I think, the patients, but the providers. And then with regards to young women, it comes back around to tobacco, and maybe that's why you asked it in that way. And that we know that particularly for premenopausal women, tobacco is a much more powerful negative effect on early myocardial infarction. And having that awareness can sometimes shift the conversation for patients.
I really appreciate the way that you zoomed into specific cardiovascular outcomes. And I want to take advantage of that. While we're talking about a range of different risk factors and disparities between men and women, I'm just going to pick out three major areas of cardiovascular disease that occupy a lot of our time in the clinic. You talked a little bit about atherosclerotic disease, whether that's coronary, or we could also think about peripheral arterial diseases or aortic diseases for that matter. And then let's talk a little bit about that versus valvular diseases, and then a little bit about heart failure. And I'm wondering if you could help us understand how these different risk factors and disparities might be reflected across the range of those different conditions.
Well, now that's a bigger question, isn't it?
It was a big question, but I thought you were up to it. So
I'm there.
Yeah.
So I think the important piece of what you're getting at is we do tend, and patients sometimes think heart disease means heart attacks. And again, as the paper really articulated, looking at, globally, there's such a difference in valvular disease. Rheumatic heart disease is still a huge problem in less developed countries and lower economic countries. And what can we do about that? That is also around a lot of what we're talking about, let's be honest, is about social determinants of health. It's about health equity, and it's about access to care. So if we look at valvular disease in high income countries or lower income, it's a difference between rheumatic disease, for example, endocarditis that doesn't get treated, and degenerative or atherosclerotic disease essentially of the valve. So those risk factors overlap for degenerative disease, but in developing countries, it's a different, in some ways it really is a communicable disease because it's infectious. And when we talk about heart failure, it also varies around the country, and it varies within our country. It varies by gender. We see that heart failure with preserved ejection fraction is more common in women and in elderly women. So getting folks to understand that and the approach can be different. We also know that heart failure with preserved ejection fraction, for example, has all these comorbidities that underpin it. For example, untreated hypertension or prolonged hypertension, diabetes, obesity, physical inactivity. And it is this collection of things that seems to underpin some of that, for example, in heart failure, preserved ejection fraction. I think those are our take-home points. I think the other piece is, as we look at these, it's also getting patients to not only have the knowledge, but the access to the same quality of care and the same access to risk reduction strategies. We talk about high and low income countries, but if you look within the United States, and the CDC has, these amazing graphics, which you can dial in, and the difference between smoking or risk factors for different states, and then even within a state for different counties. And I think if they had the data, we'd have it by zip code, is pretty dramatic. So understanding that, which again gets back to the issues around health equity, I think can help us better target each of those different pretty large areas of cardiovascular disease.
Yeah, such a complicated topic, and you covered a number of really important things there. And I'd like to finish off by bringing us back to a point that you made right at the beginning about implementation and gaps in implementation. As someone who helps lead a health system, as someone who brings science to the bedside, where are the gaps in implementation, and what do we need to do better?
Yeah, I think that, we know a lot of what the problem is, and I think people feel overwhelmed. So the gaps on implementation get at the community. I think it also gets at this team-based care and engaging our community members. There's been research done, that beautiful study around barbershops doing a better job at implementing hypertension treatment. So what can we do outside of that 15-minute office visit? What can we do after that, 2-day in-hospital stay and the continuity of care? So as a system, we need to connect those pieces up, not only between divisions and departments, which, we all fumble around sometimes, but also once they leave, and the whole community that cares for somebody outside of that 15-minute visit. That's a lot to ask, but I think even those engagements in the community can really go a long way.
Thanks for that really informative answer, and I would say sort of a challenge for all of us to think about how we can make a difference in that regard. I'd like to turn our attention to Dr. Wright. Dr. Wright, I'm going to ask you a pretty broad question, but you're the right person to ask this of. When we look at the trends in cardiovascular disease in the United States and North America more broadly, when we think about changes in mortality in particular, where have we been? Where are we headed? And here's the twist on the end. How are we spending money in this country? How are investments in cardiovascular care a reflection of that or not? I told you it was a big question, so I
yes.
understand that.
Yes, indeed. So we have enjoyed a long, steady decline in the death rate in the U.S. and in the event rates. And as you all know, we have leveled off starting around 2010, 2011, and are actually starting to see some increases in certain subsets of the population. So we're going in the wrong direction. And I think one of the most frightening things for me is that we're seeing that uptick in our middle age group. We're seeing it in the 35 to 64-year-olds. Not just an increase in event rates, but actually increase in death rates from, but I can't get out of my head, a largely preventable disease, so heart disease and stroke. So we're going in the wrong direction. And we've heard today from these experts many of the reasons why. Epidemic of diabetes, of obesity, low levels of physical activity, deep-rooted causes of social and environmental inequities. All of those are feeding in addition to some lapses and challenges that we see within healthcare. So the perverse thing about healthcare is that we are still spending money way downstream because we're insufficiently focused upstream. We've got challenges ahead of us.
I think you've summarized that really nicely. I want to ask you to take us down a level, as Dr. Poppas was referring to some of the geographic disparities that we're seeing in cardiovascular disease in the United States. Can you help us understand what some of those patterns are?
Yes, and I think I will echo what Athena said about the importance of getting local with data, because we can look at national trends, but it is getting into communities and understanding what's happening, as my colleagues in public health will say, in the field or on the ground. So right now, I'll take hypertension, for example. You know, we are accustomed to attributing high rates of hypertension and poor control to the stroke belt in the United States. But recent data show us that over the last 8 to 10 years, we've actually seen increases in cardiovascular deaths related to hypertension from Maine to California and Canada to Mexico throughout the country. A few bright spots in a tiny, small group of, couple of places, but generally the country's on fire, and that's just with hypertension. So again, the roots of this go deep. I'm very heartened by the focus throughout healthcare and public health and government on health disparities and getting at the social determinants of health in a way that I've not seen in my lifetime. I'm very hopeful about the impact that will have.
It seems important to reflect on the role that the COVID-19 pandemic has had on cardiovascular disease, and you seem like the right person to ask this question of. Can you help us understand not just how the pandemic has revealed aspects of cardiovascular disease in the United States, but maybe how it's given us some ideas about how to move forward?
Yes, wouldn't we all love to take some positive lessons from this horrible experience throughout the globe? So first, as we all know, the inequities that were present, resulting in a more vulnerable population or a less resilient population. That was identified early on as we started to see Hispanic Americans, Black Americans, Native Americans being hit at much higher levels than whites, for example. And then lots of people have looked at the reasons why. What we have learned is that we still have enormous challenges in identifying early and adequately managing the chronic conditions that made those subsets of people more vulnerable, and also addressing, again, the social determinants, the transportation issues, the neighborhood, the environments where people live. But fast forward to some of the good things we may take out of this pandemic is the patient-centeredness of telehealth and telemedicine. And many people, clinical people, knew those benefits, but they were unable to implement that kind of care because of a poor payment policy. And so getting the payment aligned with the kind of care that people want to practice and that it's actually good for patients, more convenient for people, I think is a wonderful takeaway. And hopefully that kind of access can be maintained and can help us overcome some of the geographical and transportation issues that people have faced for years.
In many countries, health systems are really driven by health policy set at the national level. The United States has a different model. However, there's a really important role for national health policy despite that. And I'm curious if you can tell us a little bit about the role of national health policy in the US for addressing disparities and trends in cardiovascular disease. What's the role of the federal government, or what's the national role here?
Yeah, I think what comes to mind with that question is the benefit of a policy that, when it comes to healthcare, that pays for outcomes, that funds the infrastructure that allows us to access data that helps inform decisions, both in a clinical care setting and in those who are in policymaking positions. So a timely, complete surveillance system would be a huge asset. And again, the value-based payment models that we've seen in places and pockets around the country, but is not yet as pervasive as we would like. I think those two things would help. Dr. Hu mentioned the profound impact that trans fat elimination has had on the health of the country. Reaching for some guidance about sodium and getting industry on board to help gradually provide more and more lower sodium options for people. Lower sodium and affordable options for people is also another great example of how policy can create health.
I think given the framing of our discussion today by the Global Burden of Cardiovascular Disease and Risk Factor paper published in the journal, I want to give you your last question here, and it's really about surveillance and understanding how we can collect the right kind of data to try and address these issues, with eyes wide open so that we know where we're headed. What's the future of surveillance for cardiovascular disease, and how can governments and health systems and physicians and citizens know what's going on? What's it going to look like in 10 years, and where are we going?
Well, I would love to have that crystal ball. What I will say is that one of the most painful, non-directly health experiences of the pandemic, in other words, didn't involve loss of life, but was the fact that we got caught, this country got caught on its back heel in terms of understanding where this pandemic was hitting and who it was hitting. We didn't have the system set up that would allow us to very quickly identify populations who were suffering. And that should not happen. And ideally, another outcome of the pandemic will be that we are as agile and as complete with our chronic condition identification, detection, treatment, management outcomes as we are growing to be with our COVID systems. When I am in contact with the teams on the response, I am jealous of what we're able to do and the insights we're able to glean from these more timely systems. So that's what I hope the future is, and I don't want it to be a decade from now.
Thank you for your insights, and thank you for the work that you're doing, both related to the COVID-19 pandemic and at the CDC in general. With that, I would like to ask our esteemed panel if anyone has any additional comments that they'd like to provide on cardiovascular disease in the United States and where we're headed and how we are addressing the disparities that we see. In North America, we know that cardiovascular disparities are persistent. We know that they are local and present in almost every community. We've talked about air pollution. We've talked about dietary risk factors. We've talked about tobacco and disparities between men and women and across the age range. We've talked about policy at the national level and related to the pandemic and with other issues. And I think I'd like to close by asking each of you to suggest a gap in either the science or the policy related to cardiovascular diseases in the United States that you'd like to see addressed in the coming years. And maybe we'll go back and start with Dr. Brauer.
So one additional thing to mention, I indicated that air quality has improved in North America, and it's really been a success story. We do also need to be aware of the global context, and especially when we have immigration to countries in North America from places that are more highly polluted, we don't really have a great understanding on exactly what the relevant exposure windows are for development of cardiovascular disease in relation to air pollution. We see that both immediate exposure has impacts, but we also tend to see that chronic exposure over the lifetime has impacts as well. So we need to be aware actually of an individual's history. What have they been exposed to recently? What are they likely to be exposed to in the future? And actually, what have they been exposed to throughout the course of their life to really understand their risk profile? And I think that's an area both for clinical practice, but also for research to really try and understand that a little bit better.
Dr. Hu.
Yeah, I want to go back to what Janet said earlier about sodium reduction. As Janet mentioned, I think the trans fat reduction is perhaps one of the most successful public health stories in the past several decades, but we have not been very successful in terms of sodium reduction or sugar reduction because 70%, 80% of sodium come from processed foods. So individual behavior changes are not going to be very useful or effective in reducing sodium consumption. So that's why I think public health policies, including sodium labeling in packaged foods or in processed foods, and also regulations in terms of food industry manufacturing, that can be much more effective in reducing sodium consumption overall in the population. And in terms of sugar, the consumption level is still very high. I think, especially among children, consumption of sugar-sweetened beverages remains very high, especially in minority populations in urban settings. And so the tax has been implemented in various countries and also in several cities in the US. Many studies have found that the appropriate level of soda tax is effective in reducing soda consumption and can have long-term beneficial effects in reducing weight gain and obesity. But in the US, again, only a handful of cities have implemented soda tax. And I think that's an area we need a lot of work in terms of political leadership and also implementation in local levels to implement this kind of policies to reduce consumption of added sugar in the US population.
Thank you. Dr. Poppas, a last word from you.
I'm going to say it's going to be the science and reinvesting in the science. NIH funding is important. We have to be clear that it's also inclusive and be sure that we're also investing in the researchers, that we have physician scientists that will really help do some of the discovery. And part of that is also implementation science. It's nice to know it, but we also need to know who we're reaching and making sure that we're reaching them appropriately.
And Dr. Wright, you get the last word of the webinar. Please help us think a little bit about the challenges for the future.
Thank you so much. I will tag on to the implementation and just call out the paper, because throughout that paper, there is emphasis on the implementation. So if we implemented what we already know works, but we made sure that we did it everywhere for everyone, that would be awesome. That's my first, but my second one is we need to understand the impact of racism and of discriminatory economic practices and other factors that are at the root cause of cardiovascular disease. And as quickly as we can understand it, to again, find out how to implement the changes that will push back on those forces or right that ship. That to me would be a tremendous and long-lasting contribution to cardiovascular health.
Thank you. I'd like to thank each of you for your contributions and this really fascinating discussion as part of the Global Burden of Disease, NHLBI, JACC journal collaboration around global burden of disease and risk factors. And I very much appreciate your time, and I hope that our audience has found this as fascinating as I have. Thank you.